Hello everyone and welcome to Metafe. And from today we are starting the CVS series from Harrison. First of all, I would like to apologize to all of you because we were inconsistent in previous months because of some people coming in our team, some people leaving our team, and so we were a little bit disturbed. Now we are trying to again form the consistency, and we will be studying CVS and then other topics from the Harrison in the medicine. Okay, so the first thing is the approach to the patient with a possible cardiovascular disease. The chapter is really very small, and there is nothing to mug up. Okay, this is all about understanding the cardiology and basic symptomatology and the diagnostic approaches. Okay, the important thing in this is the NYHA classification that we will be discussing, and this is the new approach in which I have already highlighted the important things that we have to study in this chapter. And after the chapter, first we will be reading this highlighted things, and after the chapter I have already made some notes, so we will be revising these things from the notes. Okay, so starting with the magnitude of the problem. Say in the Indian scenario, the magnitude of the problem is much larger than the Western, and because of the Harrison book is from United States. Okay, so the majority of epidemiology and this magnitude and all these things are from the US part. So I am skipping this, the natural history. So the natural history: cardiovascular disorder often present acutely as in previously asymptomatic person who develops an acute myocardial infarction. Okay, so the first thing that that it is trying to tell us is that it can present as an acute event, as an acute myocardial infarction in a patient who was previously completely asymptomatic. Okay, or a previously asymptomatic patient with a hypertrophic cardiomyopathy with a prolonged QT interval whose first clinical manifestation is syncope. So syncope is now you know that syncope can be a manifestation of a CVS disease. Okay, similarly a patient with hypertrophic cardiomyopathy may have had a heart murmur. Now whenever a patient or a person comes to you for a general checkup, you must try to hear the heart sound of the person. Why? Because if there is any kind of heart murmur or any kind of family history of a CVS disorder, then you must report it in your prescription or any the paper. Why? Because hypertrophic cardiomyopathy is a disease which can actually exaggerate very fast and can lead to very severe outcomes. Okay, so you must examine a person thoroughly for the hypertrophic cardiomyopathy. Now, the patient with valvular heart disease or idiopathic dilated cardiomyopathy, by contrast, may have a prolonged course of gradual increasing dyspnea. Okay, gradually increasing dyspnea, you must be knowing about the onset. Okay, onset is of two types: sudden and gradual. So, if there is a gradually increasing dyspnea, that can be because of the valvular heart disease. Okay. Now let's discuss about cardiac symptoms. What can be the cardiac symptoms? Different cardiac symptoms. So ischemia, which is caused by an imbalance between the heart's oxygen supply and demand, is manifest most frequently as heart discomfort or squeezing sensation, whereas reduction of the pumping ability of the heart commonly leads to fatigue. So fatigue is a symptom, chest discomfort is another symptom, and elevated intravascular pressure upstream of the failing ventricle. The latter result in abnormal fluid accumulation and with peripheral edema. Peripheral edema or pulmonary edema and peripheral edema are also cardiac symptoms. Pulmonary congestion and dyspnea. Okay. Now other symptoms can be palpitations, dyspnea, hypotension, and syncope. Dyspnea is observed in disorders as diverse as pulmonary disease, marked obesity, and anxiety. So dyspnea can be because of CVS cause, can be because of respiratory cause, can be because of obesity, and can be because of anxiety. Okay, edema, an important finding in untreated and inadequately treated heart failure, can also be because of cirrhosis and primary renal disease. Okay, so a thorough clinical examination and the investigation is must to do in a patient whom these symptoms are present. Now let's talk about the diagnosis. The NYHA, the elements of complete cardiac diagnosis include the systemic consideration of the following. This is very important. because almost everyone will remember the NYHA classification. Okay, but this NYHA classification is for the functional part. Okay, there are multiple parts of the NYHA. There are multiple elements in this NYHA guidelines. So for the first one is the underlying etiology. Etiology can be congenital, hypertensive, ischemic, or inflammatory. Then comes the anatomic abnormality, that is valvular chamber, any chamber defect, hypertrophy, dilatation, or and any valve defect, regurgitation, stenosis, etc. The physiological disturbance in arrhythmia, any kind of congestive heart failure, myocardial ischemia. And the last one is the functional disability. How strenuous is the physical activity required to elicit the symptoms? Now this functional disability is further classified as NYHA classification. Okay, so the class 4 is the symptoms at rest. The person is sitting in the room and he's having symptoms, is class 4 patient. Okay, class 1 patient is no limitation of physical activity. He can play football, he can play with his child, and there is no problem in that. Okay, so no symptoms with ordinary exertion, no limitation of physical activity. Now comes the class 2 and class 3. Class 2 is slight limitation, class 3 is marked limitation. Class 2 ordinary activity causes symptoms, and class 3 less than ordinary activity causes symptom, but the person is asymptomatic at rest. Okay, so a little bit of activity can cause symptoms, then the person will end up in class 3. If a normal ordinary activity causes the symptoms, then the class 2. Okay, anatomic abnormalities are responsible for myocardial ischemia. For example, coronary atherosclerosis, aortic stenosis are identified, and a judgment is made about whether other physiological disturbance that causes an imbalance between myocardial oxygen supply and demand are present, such as severe anemia, thyrotoxicosis, or supraventricular tachycardia. Okay, so it is trying to tell you that if there is any anatomic abnormality, try to find the physiological component of that. Okay, and then classify the patient according to the NYHA functional criteria. Okay, after clinical examination, there are 5 laboratory tests that should be done to diagnose the actual serious disease. The first one is ECG. Second, non-invasive imaging examination that includes chest röntgenogram, echocardiogram, radionuclide imaging, computed tomography, PET scan, and MRI. Okay, third one is blood test. Blood test will we will see for CRP, lipid determinations, cardiac functions like BNP. And the fourth one is occasionally specified invasive examination, and the invasive examination is angiography. Okay, and the fifth and final one is genetic test for the hypertensive cardiomyopathy and Marfan syndrome. Now family history is important for hypertrophic cardiomyopathy and Marfan syndrome, and also the any sudden death associated with a prolonged QT syndrome. Assessment of a functional impairment. The development of 2 flight dyspnea in a well-conditioned marathon runner may be a far more significant than the development of 1 flight dyspnea in a previously sedentary person. If a sedentary person comes to you and says, "Sir, I am having dyspnea," and a marathon runner comes to you and says, "Sir, I am having dyspnea," then the marathon runner symptoms should strike more hard on your brain than the sedentary person. Okay, because the marathon runner is usually getting that stress on his CVS regularly. Okay, and he is having dyspnea is a considerably bad thing. Now the presence of persistence or development of edema, breathlessness, and other manifestation of heart failure in a patient who is receiving optimal doses of diuretics and other therapies for heart failure is a far graver than a patient who is not receiving the drugs. Okay, ECG, we have already talked about ECG in our ECG series. If you have not watched it, go and watch it. Now comes the assessment of heart murmur. So the simple funda behind the heart murmur assessment is everything will end up in echocardiography unless and until the patient has normal ECG and normal chest X-ray. Okay, if any diastolic or continuous murmur is present, we will do echocardiography. Systolic murmur grade 1 and 2 and mid systolic, we will check if it is asymptomatic patient or a symptomatic patient. If it is a symptomatic patient, we will go for echocardiography. If asymptomatic patient, normal ECG, no further workup needed. If Asymptomatic patient but ECG is abnormal, we will go for echocardiography. Grade 3 or more hollow systolic or late systolic murmur, we will go for echocardiography. Then consultation. Pitfall in CVS medicine is not very important. So this was our first chapter on approach to CVS, and now we'll be revising this thing that we have studied fast. Okay. So CVS symptoms are SYNCOP, gradually increasing dyspnea, fatigue, chest discomfort, and palpitations. Now, dyspnea can also be because of pulmonary disease, marked obesity, and anxiety. Edema can be because of cirrhosis and renal disease or heart disease. NYHA, the etiology, NYHA elements are etiology, anatomy, physiology, and functional. Etiology can be remembered as CHII, C for congenital, H for hypertensive, ischemic, and inflammatory. Anatomic, physiological, and functional. Functional classification we already studied in NYHA in the book. Along with clinical examination, there are five types of tests that are mandatory. That is ECG, non-invasive imaging, blood tests like CRP and BNP, invasive examination like angiography, and genetic testing for Marfan syndrome or hypertrophic cardiomyopathy. Thank you.